afternoon and welcome everybody. Thanks for having me. So I am a gynae, and I know that this is everybody's sort of least favorite topic if you're a generalist. So I'm going to be talking about some things that are not generally in your ballpark. So when it comes to chronic illness and fertility, the presentation that your patients might come with is something that you wouldn't usually ask them about. Things like low libido, menstrual irregularities, and your patients might not think it's something very important. You might not think to ask about it, but it is really important. Fertility is a human right, and it's something that, if it's not happening for you and your partner, can consume your whole life. Everything that you think about all day long can be affected by this, and it's actually really, really important. And if you don't initiate these conversations with the patients, then they may not do it with you and not get to me for years, which is a tragedy. So first off, I think it's important for you to know what the statistics are for your patients and how much age can affect their fertility. Because chronic illness, let's face it, most patients with chronic illness are in the more advanced ages. So age alone might be a huge contributing factor. So you can see, I'm sure you've heard that over the age of 35, your fertility takes a big dive. And I know social media is sometimes misleading, because you'll see all these celebrities are getting pregnant at 50, you know. Why must you rush? Why must you rush? Go and get your degree, do you, live your life. But when you look at these stats, it's terrifying, because at 35, you only have a 20% chance of conceiving, and you have a 20% chance of having a miscarriage. That's hectic. And it's not just going to happen for everyone. And having a chronic illness makes that even harder. So in general, the effects of chronic illness on fertility can be hormonal. So if you have cancer, if you have HIV, your body, I use this analogy with the patients, is if your body it thinks that it's being chased by a lion, it's not going to be like, oh, yeah, this is a great situation for a baby. So what it does is it just switches off your LH and FSH, and you go into a hypogonadotrophic state, and you just stop ovulating. And so often our patients with chronic disease just aren't ovulatory, and they're not having a period. And for a lot of women, that's actually quite blissful, but it's obviously a problem when it comes to fertility. Structural issues can be a problem. If you've got a patient with anemia, and, you know, patient comes in, they're tired, you know, you've got that annoying patient who's just always tired. You do the workup, their HB is 11, you give them some iron, but we don't go into into why is this patient anemic? Why are they feeling this way? And actually they've got this massive fibroid uterus that's compressing everything, or they've got HIV and they've got blocked tubes, you know. Structurally, chronic illness can affect your fertility. Psychologically, chronic illness can have a huge impact, and I'm going to go a little bit into that throughout this talk. And then, of course, the iatrogenic effect. So the medication that you're giving this patient to help them might have a huge impact on their fertility. And again, this is not something that you're going to be asking your patient. So you give them their antihypertensives, you give them their antiepileptics, and you don't ask, you know, how things at home, how things with your husband, or how things with your wife. Nobody asks these things. And I know a lot of us are in these situations where we've got 15 minutes and we're like, okay, cool, blood pressure's better, off you go. But this is something that's important. For the scope of this presentation, I'm going to focus a little bit more on obesity and diabetes, because chronic illness is a huge, huge topic that I couldn't possibly do justice to. And I'm going to be talking a lot, like Ashlyn did, on prevention and catching things early. So just quickly, what do you need to fall pregnant? So 3 big things. Number 1, on the female side, you need eggs. Okay, so you have to have eggs. so you can't be postmenopausal, and those eggs need to be being released, so you need to be ovulating every month. So generally, if you're having a period every month, good sign. The next thing you need is a uterus. That uterus needs to be a normal shape, and you need to have open tubes, okay? And that's a little bit tricky for a patient to tell on their own. They would need specialist investigations to confirm that. And then you need sperm that is present in the semen, which is not a given. Just because there's semen doesn't mean there's sperm. And you also need that sperm to be good quality. So this is not just about the woman, it's about the man as well as the woman. Often we talk about fertility, and immediately you picture this woman who's sitting there crying in front of the doctor, but this is a disease that affects both couples. So let's talk about obesity. Oh, sorry. Getting overly excited here. So let's talk about the effects of obesity on male fertility, and it actually has quite a big effect. And I'm going to talk to you a little bit about how it does it, but it can affect the concentration, the total sperm count, the way the sperm looks, and fragmentation and oxidative stress in the sperm. The first way it does that is with a thermal effect. So if a male is obese, the temperature around the scrotum and testicular area is increased, and that can lead to issues with sperm motility as well as sperm fragmentation, and then increase the oxidative stress. The second way it affects it is through a central effect due to insulin resistance. So insulin resistance lowers your testosterone level, which in turn lowers your sperm concentration and motility. The next way that it affects it is with sleep apnea, and this has been found to be an independent factor from your high insulin levels. This is commonly associated with low testosterone, erectile dysfunction, and like I said, is independent from BMI actually. So asking patients without obesity about sleep apnea is also important. The last central effect is the aromatization of testosterone to estrogen in the adipose tissue. And so higher estrogen levels lead to lower testosterone levels, decreasing sexual desire as well as sperm production. The psychological impact is also huge. 79% of men with erectile dysfunction were found in the study to have increased weight or obesity. And they found that you had a 1.3 chance of having 1.3 times higher chance of having erectile dysfunction if you were obese. Now, is this a physiological thing? Is this because the man doesn't feel good about his body? I think that both lead into one another. How does it affect women? So the big thing with obesity and female fertility is PCOS. And this is something that needs to be at the forefront of your mind. So anyone who's walking into your office should be having a weight and a height, calculate the BMI, because this is a chronic disease on its own. Obesity is a chronic disease on its own. And as soon as you've identified, all right, this BMI is more than 25, then you need to be having this conversation with this woman. We need to be looking for PCOS in you. And I'll show you the statistics just now. But basically, PCOS is a genetic predisposition that leads to a hormone imbalance. So these women have LH that is higher than the average woman, and this is due to elevated levels of insulin. So the insulin is up, that causes the LH to go up, and that increases your testosterone level. That's why the women often have ovarian dysfunction. So you can imagine, if normally in your cycle, your LH is supposed to start off low, and then it's supposed to peak when you ovulate, and then it's supposed to come back down. Now, if it's high at the beginning, your body's going to be completely confused and think, oh, we've already ovulated. Okay, then I guess we don't need FSH. And so no follicle grows. And so you just have all these immature follicles around the outside of the ovary, none of them ovulating. And so you don't get a period. You don't get pregnant. Every few months, you'll have a little bit of FSH that pops through, and you'll have a random ovulation, so they can still get pregnant. It's not a sort of death sentence for your fertility, but it's very difficult to time. So they'll have this ovarian dysfunction, and then that high testosterone can be associated with androgenic features. So you all know, typically you've got this patient who's got acne, who's got hirsutism, that's all that high testosterone. So how does it work? You've got your high insulin from your obesity. That works on your liver, which also then decreases your sex hormone binding globulin, which increases your testosterone. And I've sort of gone into all of this already. This is all the sort of science behind it. So these patients are really, really at risk of developing type 2 diabetes as well as cardiovascular risks. The second way that it affects your fertility, so that's the first one. You've got PCOS, you're not ovulating. The second way is that your eggs and your embryos are affected. So your egg quality, and we see this all the time. We have ladies coming in who've got PCOS, and now they're infertile. We try to get them to ovulate. It doesn't work because their ovaries have been ignoring us for so long. So we have to give them injections of FSH to demand that their ovaries ovulate. So we get 40 eggs, which is a lot. The average person, just to give you some context, if you're 18, then we'll expect maybe 25 eggs in a normal person who doesn't have PCOS. If you're 30, then we're down to 15. If you're 40, then we're down to 5 or 6, So if you've got 40 eggs, that's a lot. But we never get 40 good quality eggs. Half of those eggs are going to be bad quality in PCOS. So egg quality is a big problem, and we found that there's actually decreased fertilization in women who have a BMI of more than 35, as well as 50% lower clinical pregnancy rates and live birth rates. The other way that it affects you is just the chance of getting pregnant is so much lower. So if your BMI is above 29, for every point above 29, you have a 4% chance less of falling pregnant. So when you calculate that, that gives you a 43% lower chance of getting pregnant if you have a BMI of 40 compared to someone who has a normal weight. That's hectic, 43%. So this really is an important thing for us to be aware of and to make our patients aware of, because they don't think it's a problem. And it really can be, especially if you're finding someone really young, an adolescent, or young people who aren't even thinking about pregnancy need to know about this stuff. It also affects your endometrium and the ability for the embryo to implant. And in our stats in IVF, we found everything really is reduced. So the pregnancy rates, they end up needing longer stimulations, higher dosages, as you can imagine, with increased miscarriage rates. So 1.3 times higher risk of having a miscarriage. The good news is that weight loss improves most of these factors. So if you lose weight, your insulin levels go down, your androgen levels go down, you start to menstruate regularly, you have improved psychological outcomes, your risk factors for diabetes, cardiovascular disease all decrease, and then your symptoms of the high testosterone all decrease as well. So what you'll often find is that even if patients are just slightly overweight, they might be having regular cycles. That does not mean they don't have PCOS. It could just be that their threshold to have their period stop is just higher. If they picked up another 5 kgs, they might find their cycle start to lengthen and the symptoms come out. But they will have PCOS forever, no matter how well controlled they are. So looking at it from the other way, which is probably the way that you guys will look at it. So you'll have these patients who present with diabetes. And so we found that in our PCOS patients, 80 to 100% of them have insulin resistance. So we are super sort of clued in to check them for insulin resistance. We need to treat it, But the other way is true as well. So 40% of reproductive age women with type 2 diabetes have PCOS. And so you guys need to be very aware of that and refer those patients to us from the beginning, because we can really help them. They might be presenting with really painful periods when they do have them. If they do have regular periods, they might have one really heavy, painful one this month and then not next month. And then this month is super painful and heavy and not next month. And I've been seeing that a lot in my patients. And they see a GP or a gynae, even gynaes, for years and never get told they have PCOS because they are menstruating and they don't have the acne. But it's because they're just below that threshold where they'll have all those horrible symptoms. A study from Sweden also was quite terrifying. They compared premagravid ladies with type 2 diabetes compared to gravid with no type 2 diabetes, and they found an increased miscarriage rate of 1.8%, an increased infertility rate of 3.4 times, sorry, not percent, times. So you're 3 times more likely to be infertile if you have type 2 diabetes. So it's super important to send those patients to the gynae for an assessment. And their birth rate is 4 times lower. I mean, it's just ridiculous. In men with diabetes, traditionally we've been told, actually, if you've got diabetes as a man, it's not really a big deal, doesn't really affect your fertility, but we found it really does in terms of erectile dysfunction. Retrograde ejaculation, not that common, but we do see it. But now we've been finding that actually, even if the sperm looks good on the semen analysis, the implantation rate and the embryo quality is low. So we're still not getting pregnancies. So we still, as soon as I pick up that this guy's got diabetes, send him to the endocrinologist, get it optimized, because even though the sperm looks good, it could be better if your sugar was optimal. So what should you guys do about it? Counseling. Make your patients aware. Just think about it. When you see a patient, measure their BMI and talk to them about their sexuality, about their period. And if you don't want to talk to them about their sexuality and period, that's fine. Just give them the number of gynae so that we can talk about it with them. And then, so then when you do refer them to me, I will assess them for PCOS. This is the Rotterdam criteria. Usually you need 2 out of the 3, but like I said, a lot of them are asymptomatic because they're below that threshold. I would scan them. What I want to see is on the left of your screen, that's normal. So a normal lining is a trilaminar lining that's built up, and you have a dominant follicle that's ovulating. On the other side of the screen, the left side, that's what a PCOS ovary looks like. It's all those little immature follicles, but none of them are ovulating. So I do that ultrasound. I do these routine bloods for them, so you guys can do these before you refer, or you can send them to us for it. But we test the AMH, and an AMH of more than 3.5 is likely to be PCOS. A TSH of more than 4 can affect your fertility and increase your miscarriage rate, so we tend to treat those. 30% of patients with PCOS have high prolactin, and so we do test that. And if it's high, then we can treat, and vitamin D as well associated with infertility. So we like to treat that if it's less than 30. And for men, testosterone, estrogen, FSH. If the testosterone and FSH are low, we can modify those with clomiphene, with Ovitrel, with antioxidants. So those kind of things can be treated. The other thing that makes the patients feel so much better is being on inositol and CoQ10. So there are a whole bunch of different brands. I'm not sure how strict we are on mentioning brands, but there are a whole bunch of different options that the patients can get off the shelf that contain these vitamins that can make them feel so much better. So just being on these vitamins can regulate them. So I don't know about you, I'm getting so much pushback on the pill. Everyone would much rather use the Flow app to monitor their periods than take the horrible hormones, which is probably the best thing for them. But if they refuse, then just putting them on this vitamin can help to regulate them, help them sleep, help them have energy, and help them with weight loss as well. So it's a really great vitamin to put them on. This is just a semen analysis, and I want to make you aware that not all labs are up to date with the correct semen analysis. So you must just make sure if you do a semen analysis that the reference ranges are correct, because I get patients coming in like wringing their hands, terrified because they've got a low morphology of 8%, whereas as you can see here, normal forms is normal at 4%. And it's just that the lab is given the incorrect reference range. So just make sure that you don't freak people out unnecessarily there. So the good news is that weight loss can really, really help with these patients. And so encouraging weight loss, whether that's through lifestyle modification, involving a dietitian, vigorous exercise has been shown to be the best for PCOS. So they say 75 minutes of vigorous exercise per week, which is not a lot, is superior to doing moderate exercise every day. So encouraging that, I think, is super helpful. And then our injectables, there's quite a lot of evidence that the injectables are really helpful in the PCOS population, as well as bariatric surgery for those who are in the BMI of more than 40 range. And so, in summary, chronic illness can have a severe impact. Patients may not bring it up, so please do think of it for them and educate them and then refer them so that we can work them up and we can prevent infertility, because I don't want to do IVF for everybody. I want them to get pregnant on their own. We can do that, and we can prevent them from getting diabetes later on in life. Thank you.